If you're doing a program, a physical therapy program, a strengthening program, and you're making some progress, but you're still getting injured doing whatever you like to do, something about that program needs to change. Some variable needs to change in order to make sure that it's actually preparing your body for the task that you're asking it to perform.
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained physician dedicated to helping you navigate Ehlers-Danlos syndromes, joint hypermobility, and complex chronic illness. Today, I'm joined by Dr. Dacre Knight, Medical Director of the UVA Health EDS and Hypermobility Disorders Center, which is proudly partnering with Bendy Bodies. Our guest today is Dr. Morgan Groover. Dr. Groover is a physical therapist who is specialized in EDS. This is such an important conversation because although we have had physical therapy conversations on numerous occasions, today we're going to be talking specifically about how to find the right load that will help strengthen your body and how to individualize your physical therapy care. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Well, I'm so excited to be back with Dr. Dacre Knight, and today we're going to be talking with Dr. Morgan Groover. So great to see you today.
It's nice to see you, and it's nice to be here. I'm really appreciative of Dr. Knight for inviting me here.
So yeah, super excited. And Dr. Knight, of course, great to see you today as well.
As well. Yes, my pleasure. Thank you.
I want to start out by talking about some of the messages that we sometimes send to our patients inadvertently. For example, sometimes people with hypermobility or connective tissue disorders, they're told what not to do. What do you think is the problem with that approach?
Well, it's hard because you're giving them a list of things that they can't do or shouldn't do without necessarily giving them the things that they can. So it's like, okay, I'm hearing all these things that I can't do and I'm trying to make sense of it. But then it almost feels like, okay, I'm not really sure where to go from there. So it can leave people like feeling more confused than when they walked into that encounter. Can also leave them feeling more fragile too, which like in this patient population, we don't really need to be adding any more of that to tissue that is inherently fragile. So to add that fragile mindset on top of it can just leave people feeling like really scared to move. And it feels like sometimes they can't trust their own body. So I feel like it's really important to be very intentional about the language that we use when we're talking to patients.
Yeah, that fragility narrative can be really tricky. And one of my patients who I've seen for many, many years and know very, very well, she has said one of the best things I ever did for her, not all the prescriptions, not all, but that I told her, you're stronger than you think you are. And she then started to try to do more, which of course our tissues respond to load, right? Which we're going to talk about in a few minutes. So treating our bodies as more fragile than we need to sounds like something we should try to avoid.
Absolutely, you're right. Because that patient then just, it like further exacerbates that cycle of like fear of movement, tissues being deconditioned, and then trying to load from there just becomes harder and harder. And trying to figure out where that starting point is really important.
I know you mentioned to me we had a little bit of communication via email before this meeting, and you mentioned about a gap between, not overdoing it, but also the risk of underdosing or mismatching load. Can you explain more what you mean by that and also what you see clinically?
Yeah, so typically with my practice, the way that it is now, I've switched more into mobile physical therapy. So I tend to get patients at their houses or at the gyms. And so it's a little bit different than in like a traditional clinic setting, where I'm now getting patients coming to me kind of in two different camps. Either, the more athletic type where traditional physical therapy may not be challenging them enough to meet the tissue demand of like the activities they want to be doing. If they want to be running, if they want to be lifting, and they go to a clinic and the heaviest dumbbell in the clinic is 10 pounds, then like that's not ever going to meet like the proper dosage for them. And then on the flip side of that is the patients that I tend to see in their homes at a little bit more homebound, bedbound, lower activity. And just getting to a clinic is a struggle for them. So then the physical therapist really has to work with them to figure out that appropriate starting point. But then again, we really want to be able to challenge them because the tissues aren't going to change if we never figure out like how to challenge them just enough to make that appropriate change. And so if they're consistently doing, 3 sets of 10 generic exercise prescription of, a bridge, how are they ever going to be able to lift their kid up off the floor and put them in a car seat or something like that, like something more functional? So we have to make sure it's really just about individualization. You can talk about two sides of the coin, but it's really a spectrum of like, you have to figure out where that patient is that's sitting in front of you. And that changes day to day. It changes minute to minute sometimes. So it's really ongoing.
And I think so many people have tried physical therapy and they think, oh, I was injured doing physical therapy, or it doesn't work for me. I know Dr. Knight and I have talked about this. We both have, had people say this. And it's hard because, there's the fear, there's the like, oh, how careful do I need to be? But then if they go to a physical therapist who doesn't understand these things, sometimes they can be given prescriptions that are too difficult for them or home exercise programs that are too difficult for them. So what do you say to those patients?
Yeah, and I feel like we talk about this part a lot. Like, this is kind of the messaging that we see online most of the time. And I get a lot of patients with this. I even got a call from a new patient yesterday who was saying this. And he's like, yeah, I've tried physical therapy before and it didn't work. And every time I hear that sentence, it just breaks my heart a little bit because I really enjoy what I do. And I feel like there's really positive changes that can be made. And so when I hear that someone had a bad experience, like, I'm automatically asking more questions about what that experience looked like, both from like how the patient kind of perceived that interpersonal interaction between them and the physical therapist. Was it a true partnership? Did you feel comfortable telling them, hey, this exercise is too challenging, or I feel pinching in my hip when I do this exercise? Was it an open communication situation? Um, did you try to voice those and then they weren't received well, or there weren't any adaptations made? What were the exercises that you did? How did those make your body feel? Did you feel like you had any sort of carryover to functional things throughout your life? It's fine if you're progressing on a certain exercise and then you're feeling like you're doing really well making all these gains, but then if you can't get any sort of functional carryover into your daily life, then like, are they even worth it? So it's having that conversation like super early on and then being able to have that conversation with every single patient encounter after that. And that's why I think physical therapy is such a cool field. Of course, I'm a little bit biased, but that's why I went into it, is that we have like more time per session and just over the length of the plan of care to actually get to know these patients and figure out like what they're actually trying to get back to. And it's easier for me to kind of pick up on those day-to-day changes of, okay, where can I step in and help this patient get to what they want to do?
And I love the emphasis on function because, of course, at the end of the day, you could lift all the weight you want, but if you can't carry a bag of groceries, or like you said, if you're a mom and you have a young child and you need to be doing things with them, so I really appreciate that. And some people are dealing with dizziness. Like you said, they have difficulty getting out of bed or those kind of things. So people who are already feeling like really unpredictable in their bodies, how do you approach that?
I feel like that's where that patient interview comes in. It's so important for so many reasons, but you need to know the contextual factors of like what's going on in that patient's environment, in their system. So like you said, like MCAS and POTS are typically the two things that I see most commonly with patients with EDS or even just undiagnosed hypermobility. And so these are things that we have to think about at every patient session, and like within a session, it might change too. But there are things that we can do in physical therapy if someone's having a little bit of a higher like systemic symptom day. I always tell patients like, don't cancel your appointment just because you're having like a POTS flare up. Like, that's actually a really good time for me to come in and try to help you mitigate those symptoms so you can feel better. My goal is always for you to end the session feeling better than when you started. And so like a lot of times I'm spending more time doing manual therapy, some soft tissue work, some easy joint mobilizations on the thoracic spine and rib cage are one of my favorite things to do for POTS treatment anyways. And so maybe that's where we spend a little bit of extra time on those heavier, like extra noise symptom days. and overall just like bring like down that nervous system and be like, oh, okay, we can still get some work done. Like, I know you didn't think we could when we started the session, but we've brought it down from like, a high level down to now it's more manageable. We can try to get some loading in and still feel really productive and feel better than when you started.
Let's say it's like a patient's first visit and it's hard to get an assessment, I'm sure, at the beginning, but as a starting point as a physical therapist, how do you know where to start with a patient, or how would you understand what their baseline might be to work from?
Yeah, so I ask a ton of questions on the first day, and I always kind of give that caveat, like at the beginning of the session, of like, this is going to be a lot of talking. If I'm ever talking too much, please tell me, and we can move on. That's typical for me, but a lot of my patients enjoy that because that's a whole hour of them getting to tell their story, and so it might be the first time someone's had that time to really sit down with them and like, no, I actually want to hear every single thing that you're struggling with. What does it look like day to day? I want to know what a bad day looks like. I want to know what a really good day looks like. And then what's your average? And so, also, what are we dealing with today? Because today is like the only data point that I'm getting from that person in front of me. So, I need that extra information. I have to rely on them to tell me that. And a lot of times, like, they feel really validated going into that encounter, just knowing that they are able to express all of that and have someone sit there and try to piece together the puzzle. And so back to your question of like, how do you even know where to start? Usually the patient tells me. They might not know that they're telling me, but I'm taking everything that they're saying and figuring it out as data points. Okay, their symptoms tend to get flared up doing X, Y, and Z. Okay, maybe we don't start there. Maybe we modify. Okay, if they get really dizzy going from sit to stand, we might do mostly laying down or sitting work today. We might do most of the assessments trying to figure out what might be causing that. Is it POTS? Is it some sort of vertigo? That's kind of where I start my assessment of like, just based on what they're telling me. And then my favorite question to ask is, what are your goals? Because that automatically tells me what I need to be looking at. If they're having trouble with getting up and down the stairs, I'm certainly going to want to watch them go up and down the stairs because I can come up with like the world's greatest exercises for whatever. You go online, you look up top 5 exercises if you're having anterior knee pain with stairs. I want to see how you're doing that because like how you have knee pain going up and down the stairs might be different than someone else having knee pain going up and down the stairs. So that's one of the other benefits of the mobile model is I get to see patients in their home environment where they're actually having the symptoms and be able to watch that motion break down kind of where, okay, I feel like this sort of motion might be where you're having a little bit of instability, or I see that that motor control is not quite there for the full range of motion, and that's where you're getting the knee pain. So let's take this motion that you're having trouble with, break it down into smaller components. Okay, we decrease the depth. We practice that little motion in a smaller range that you do have control over and gradually build it up from there.
Yeah, that's great. And that's what I have actually told some of my patients who I've referred to you. So beware, you might have another spike of referrals after this episode. That being said, so you get all this information, you understand kind of baseline capacity, and I'm sure there's a little bit of wiggle room, I guess, to where you start with, and you kind of tailor that over ongoing visits and so forth. What are, in your experience, what are some of the risks of like doing, I think we've talked a little bit about of doing too much, but also doing not enough. So what you might call underloading for patients for follow-up visits and things like that.
Yeah, so especially with the hypermobile population, we know that those ligaments are going to be a little bit more lax. You're going to have a little bit less of that passive stability and support at the joints. And so what helps with active stability is the muscles. So if we're chronically underloading these patients, those muscles never have that stimulus, that signal to say, okay, we need to get a little bit more robust so that we can handle this load that this person's asking me to do. I tend to refer to bodies separately from the people that are inside of them. One of my patients calls the body the meat suit, and like I can't get it out of my head now.
That's a good
So
one.
if you hear me talk about the body versus like the person, that's what's going through my mind. But it's all about that connection between you and your body. And so we're trying to figure out, okay, can we get this muscle, this whole group, this team, the group project to all work effectively. And by loading that muscle tissue, the tendons, we need the tendons to be stiff. We talk about stiffness in a bad way sometimes, but tendons actually respond really well to the load you give them. You need a little bit of that stiffness in order to handle the things that you're asking the body to do. And so if we're not meeting the demand that this patient goes throughout their daily life, or if they have certain activities they like to do, those tendons have no reason to adapt. The muscles have no reason to adapt. And so they're just being overwhelmed by the tasks that they're trying to do. That can lead to pain and fatigue. It can lead to a lot of things.
Yeah, sure. And I can imagine it could be certainly very detrimental. So, and when so when you're working with them and you're trying to, circumvent those bad outcomes, what do you do as far as like your assessment on how much, what is their capacity and underloading, et cetera? Are you're kind of measuring their intensity of the exercise, or you're giving them more exercises to do to kind of raise it up? How do you approach that titration, I guess, is what you're doing?
Yeah, there's a bunch of different factors that you can manipulate when you're trying to make something harder or easier. Um, so like a typical thing that people would think of is like the number of repetitions of an exercise, or the amount of weight that you're moving, or the strength of the band that you're using for an exercise. But there's a lot of other variables that you can change. So if someone's like, "Oh, I feel like this weight is actually like enough to challenge me. I don't think I could handle a heavier weight." Something I can change is like the tempo of the exercise or the range of motion that you go through. So we need to be able to strengthen through a full range of motion. And this is a little bit controversial for hypermobile patients of like, you get the advice to stay out of the end range. The end range is where bad things happen. We can dislocate, and we got to like really work on how we talk about this. Because we need to get strong in those end ranges. End ranges happen. I mean, we live life, mostly in the mid ranges, but a lot of activities and daily demands involve going into end range motion. So we have to figure out, okay, what is this patient's safe end range that they can handle? And safe really just means what the tissues are able to control. And so how do we gradually build that up? Okay, well, we can slowly increase the range of motion through which they're taking this exercise. We might stay at the same weight or the same rep count for a while, but we're changing all these other variables in the background to just challenge the system a little bit more. You don't want to change all the variables at once, because typically the system gets overwhelmed and you might not know which variable is the thing that did it. And so it's like an experiment almost. You got to figure out, okay, which independent variable can we manipulate today? And then see how the patient responds both in the session and in the days after the session. So if I see someone once a week, twice a week, their job is then to give me that data of what happened in between the last time I saw them and now, so that we can figure out what to do for this session.
Got it. It must be satisfying to see that progress too over time.
It's so cool. I mean, even just earlier this week, I had a patient who actually is someone who introduced me to this podcast. She's the one that called you out for saying there's no joy in physical therapy, Dr. Knight, which is how I ended up here, because I then called you out. But she's a 15-year-old girl, just for prefacing. And she had injured her ankle and then injured her back because of how she was walking on her ankle. And it ended up in a wheelchair because she was so afraid to walk on it that she was going to injure it more. And so I've been seeing her for a couple months now. I think we started back in December. And just on Monday, I was able to get her to do a squat with a 25-pound plate held in front of her chest. I had her doing heel raises with a 25-pound plate overhead. And I'm telling you, I thought she was going to cry. I thought I was going to cry because she was so happy to be doing that high level of exercise. She's like, I never thought I was going to get back to doing these things. And these are things that make me so happy. I'm like, girl, that makes me happy. Like, I love that you're happy. This is why I do this. And so, of course, I'm, going to be curious to see her next Monday and see how things are going since then. Because, it's typical. We can have flare-ups after we increase the dosage of these exercises. But even just that moment of joy can be worth it sometimes, to be like, oh, okay, I was like a little bit sore, might have overdid it. Let's adjust. But like, how cool is it that she did it,
You mentioned that you obviously find your work very enjoyable, and that's great. And what I am curious about, and you touched on it a little bit with this encounter, is about setting expectations for patients, right? And we had previous episodes. We talk about like what is the magic pill for problems with EDS and HSD, and there is not a magic pill to set expectations, but there may be some magic in the process of going through these treatments and therapies and so forth, and bit by bit we might find some progress that is really bringing us joy and satisfaction both as providers or patients. And so, you know, thinking through that and my kind of clumsy way of getting some guidance in place for others to think about of making the progress or the process of it something that we enjoy rather than just the end result and the end expectations that you do physical therapy and then lo and behold all of a sudden you're going to be up walking up and down your stairs without problems. So if we can find ways that we can reach some joy in the process of it, that's I think is the real key. And but if you can, then just talk about what you may work towards in order to bring joy to physical therapy for someone doing physical therapy, where it's not just a kind of a rigorous go to the gym and go exercise, and patients are reluctant to do that. How can they find joy in that method of treatment?
I think you just have to make it meaningful. I think like a lot of patients and myself as a provider can find a lot of joy in making it meaningful. I don't know about you, but if I go to physical therapy or really any encounter and I'm just, told what to do, and it's like, well, I don't really care about those things. I'm certainly not going to go do a home exercise program if I don't, understand how that's contributing to my overall well being and if I don't like it. I think your home exercise program is a way to kind of figure out what movement feels good to you, what you enjoy, because the best home exercise is the one that you're going to do. And so a lot of people ask me, what are the best exercises for someone that's hypermobile, or what should I be doing? And it's like, well, what do you like to do? That's always my first question. What do you like to do? What do you want to be doing? If I could snap my fingers, that magic pill you're talking about, if I could just snap my fingers and fix everything, what would you be doing? And a lot of these patients have a hard time answering that question, especially in the chronic illness community. It's hard to kind of have those big dreams because what you thought your life was going to look like is now different. And we have to take that reality into account. But a lot of my job is just helping patients figure out, okay, what could this look like? What could my goals be? Because sometimes that is a hard question. And so some of my sessions are just sitting there being like, okay, well, what did you used to like to do? All right. Well, what short-term goal can we set and then reevaluate? Because long-term goals are scary for people sometimes. It's hard to think big. So kind of helping them have that conversation of okay, what do we want to be working on? And then that's how I set my plan. Because it has to be meaningful or else you're not going to do it. And consistency is the only way that we can make change. So getting to that point is really important.
So let it be known for all of our listeners, we've got it on record now. Morgan Groover has said you can find joy in physical therapy. So
Absolutely.
something for everyone to look forward to.
And I, as somebody who has been in and out of physical therapy, mostly since I was a teenager, and I'm obviously not a teenager or even close to it anymore, I do agree. And I find joy in physical therapy also, but I definitely have gone through periods of my life where movement and, quote, exercise were things that I, didn't look forward to and didn't enjoy as much. And then other times where I did. So I think what you're saying about meaning makes a lot of sense, because if we want to be able to move, then we have to move, right? We can't just kind of, pick and choose and all of a sudden think that we're going to be able to do these incredible things if we're not moving on a regular basis. And so I think that I've seen studies about how people view exercise and movement being very impactful for how much they do movement type things. I don't know if you're familiar with the studies that I'm thinking of, Morgan, but do you know what I'm talking about? If you think of it as a negative thing, oh, got to go exercise. Whereas a lot of people are I get to exercise. I think that makes a big difference.
It's a little bit of that self-fulfilling prophecy of okay, if I think negatively about this, my motivation is out the window. I'm not going to go do it. And so you have to find those little bit of like, okay, I actually really like doing this. It might not be like the most research, evidence-based movement, whatever prescription, but I enjoy doing it. And so I'm going to go do it. And that's better than doing nothing. So I'll take it.
hmm And I wanted to point out too, following up on, first of all, I love the meat suit. That's hilarious. And I think sometimes we do get too overly attached to our bodies. So I think in a way that's really good of like being able to view that separately and to try to view it objectively and see, oh, what do I need to work on or whatever. But I also wanted to circle back to when you were talking about, sore muscles. And I see often with my colleagues, and I don't know with Dr. Knight how often he does or doesn't do this, but not that I'm aware of anyway. A lot of them will prescribe muscle relaxants. They'll be very heavy on muscle relaxants for muscle pain. And it's my understanding that a sore muscle is very likely a weak muscle, and that it might not be that that's the underlying problem. It might be a different muscle or a different neuromuscular pattern. But can you comment on that in terms of painful muscles and what the significance of that is and the approach that we should be taking?
Yeah, so typically I see soreness or really any type of pain as a signal. The body's just saying, hey, something's going on. It doesn't necessarily mean something's broken or wrong. It just means something's happening. It's your body's way of alerting you, hey, I like think something is like not quite right. I'm not happy with how things are. And it's trying to get you to change something. So trying to figure out how to interpret that signal is like really important. And it's very individualized because, if you're a really heavy power lifter, you're going to expect a certain level of soreness every time you go up in weight. And like, they almost feed on that. They're like, oh yeah, I had such a tough workout yesterday. Like I got the burn, I'm sore. But then someone that's not used to lifting all that load suddenly starts to move and they feel that muscle soreness, maybe even for the first time of like, oh my gosh, like that exercise hurt me. And that's where I'm like asking way more questions of like, okay, let me give you some pain descriptors or like sensory descriptors, and you kind of tell me what fits the best. Like if they can't come up with it on their own, I'll give them a couple of options. I'll make it multiple choice to be like, okay, is it like burning? Is it sore? Is it sharp shooty? Is it dull achy? I have like a ton of different descriptors that I use, and most people will like connect onto one and be like, yeah, that's the closest to what I can describe. And so based on that information is kind of how we can change the exercise or modify, certain factors to make it easier, more challenging, or just different altogether. So back to your thing about muscle relaxers is like the muscle being tight or like in that hypertonic state is not always a bad thing. So being able to take that as data and being like, okay, maybe the interventions that we're doing right now are not quite right. Maybe they're not at the right dose, or maybe we need to do some manual therapy techniques to get this tissue moving more appropriately so that when we load it, it can actually have the chance to adapt. So when you have something like muscle relaxers, it just makes the data a little bit more confusing to interpret. But it's like not necessarily a bad thing. It's just something to keep in mind of like, okay, if this patient's on muscle relaxers, they might not have that feedback as readily available if they're not getting that input from the muscles.
And sometimes I think people, because it causes a little bit of sedation or something like that, so it might actually feel like the pain is better or their experience of the pain is a little bit better, but it's not because of a direct effect on the muscle itself or necessarily a beneficial effect, right? It's more of a Band-Aid than actually getting to the root cause. And I really think that this part is so important about going back to the physical therapist and talking to them, because at least in my experience of people who have said that physical therapy doesn't work, they also didn't go back to the physical therapist and explain to them, what their experience was. Because like you said, that you might say, well, that's what you're supposed to feel, or, okay, now that you told me that, now I'm going to modify this exercise. But if you don't go back, then the physical therapist doesn't have the opportunity to do any of that.
Right. And that's why I was saying it's so important to treat it like a partnership. So if you don't feel like you have that sort of relationship with your physical therapist, it's really important to evaluate that, because for hypermobile patients, physical therapy is almost like a lifetime thing. I tend to like tell people it's episodic. You're not going to be seeing me every week for the rest of your life. Like, please no. We have ways that we can get through and manage like certain things and then take a little bit of a break. You do the work on your own. And if something flares up or you get a new injury, that's where we start to come back and see each other more regularly until we fine tune it and get you back on your own. As much as I love my patients, I don't want to see them every week. I want them to go out and do the things that they like to do. And so I think having that conversation of like, this has to be an ongoing partnership. And if you're just not getting the right vibe in terms of, my physical therapist doesn't really listen when I tell them, that I'm feeling certain things, they're not really able to adapt kind of on the fly. It feels like they have this structured list of the exercises we have to do today. Or they're in a clinic where they're not even working with the physical therapist for their exercises. They're working with a tech. And that tech has been given a list of exercises and they're just running right through it and not even looking at what the patient's doing. Like, that's not very good skilled one-on-one care for that patient. For some patients, that works just fine and that's what they need. But if you're feeling like you're not getting enough out of that interaction, it might be time to figure out if you need to see another physical therapist and find the right fit.
Yeah, that's fantastic. That's great information. We are going to take a quick break. And when we come back, I want to ask you a question that it's not even related to anything that I shared with you ahead of time, but I think it's a really important point that I would like to make. You just said something about skilled. And I think a lot of people nowadays don't understand the difference in skill sets of different, clinicians. So like a physical therapist versus an occupational therapist versus a gyrotonics instructor or a Pilates instructor or an athletic trainer. And I have so many patients who, they might go to one of those people at gyrotonics, Pilates, and those people are great, by the way. I'm not trying to disparage any of those people. But at the same time, I think it's important to understand, what you're going to get from going to different people and working with different people. So we're going to take a quick break. And when we come back, we are going to talk about that. We'll be right back. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again and enjoy the rest of the episode. Okay, very excited to be back with Dr. Dacre Knight and Morgan Groover. So I mentioned before the break, and I feel like this is such an important conversation to have about skill sets and where people can add value, because a lot of people do find benefit from working with a Pilates instructor, a gyrotonics instructor, an athletic trainer, all of these fabulous people who have their own set of training and they can offer different things to people that are hypermobile or have connective tissue disorders. But I want people to understand that the physical therapist training is going to be different and it's so much more medically focused. So can you explain where you think there might be some confusion and or what do you think people should know about those differences?
I think it's important to state that everyone has someone out there for everyone. And you can't be everything for everyone, but there is always someone for someone. And so finding the right fit for what you need at that moment in time is really important. Maybe you've done really well with physical therapy and you've kind of gone through that more medical route and now you're more independent, but you're not quite ready to go back into independent exercise. You say, oh, well, I really like going to Pilates. I like doing reformer work. Maybe I'll go find a Pilates instructor that has a lot of, experience working with hypermobile people. Great. Have fun. Let me know how it goes. Maybe I'll go to a class with you. That sounds really fun. Or this gyrotonics thing. People are really getting into that now. And it's okay, if that's working for you and you feel like your body is enjoying that movement and you're able to handle it and you feel really good doing it, by all means, please go. But I think where people get tripped up is with more of the injury and pain side of things. If you're, going to an athletic trainer, if you're going to a chiropractor, you can name any sort of profession here, just fill in the blank. And they're like, oh, my so-and-so said blah, blah, blah. And it's okay, did you have that medically evaluated? Did you go see a physician? Did you get imaging? Did you see a physical therapist? Because physical therapists, are going to handle more of that musculoskeletal complaint. no, my so and so just said, oh, based on what I've seen in other people, I think this is going on. So this is what we're going to do. And there was like no sort of assessment or evaluation. And so then it's like, okay, did that work for you? If it did, great. Like that might have been a little bit of luck, or that person just happens to know more than what their baseline training would be for their profession. But if not, like come see me, come see a physical therapist where we can actually diagnose like what's going on musculoskeletally. And then if I find that I'm at the limit of my scope of practice, I always have a very thorough list of referring providers that I'm like, hey, I don't know what's going on. Go see this person because I know they're going to do a really good job assessing you. And I think that's part of like having almost like a quarterback for your care team with like that giant list of referrals is like so helpful. And I feel like I've fallen into that role a little bit with my patients of like, they'll say, oh, I'm having like this GI thing going on. Of course, first with my pelvic floor lens, I'm asking pelvic health questions to see if it's something that falls in the scope of pelvic floor physical therapy. And if not, I'm like, these bowel complaints, along with your like history of really bad periods and maybe some infertility, point more towards something like endometriosis. I can't diagnose that, but I have a list of 3 people in the area that you can go see. And so kind of like directing care that way, whether that's, more on the medical side or more on like, the recreational side of, Pilates, like you mentioned. It's good to kind of know where to send your patients so that they don't just like get lost out there trying to figure it out on their own.
Yeah, and it can be really tricky if they've had a negative experience with a physical therapist or some other type of, you know, provider or clinician or whatever. And so then a person, I think, sometimes can end up, like we talked about at the very beginning, kind of really turned off and throw out the baby with the bathwater. And that's what we're really trying to tell people today is, number one, you can absolutely have joy in physical therapy. And I know for sure for me, it has been, just tremendously beneficial. And it's kind of like dating where, you might have to try more than one person before you find the one that's the right fit for you. And I do know that too, that there are a number of clinicians that will unintentionally reinforce fear avoidance cycles. What would you like to say to the clinicians that are listening right now regarding that?
That is so important because I feel like I even have to catch myself sometimes. I can usually control my words pretty well. My face is another story. And so I feel like that's going to resonate with a lot of clinicians too. And so, when you're going through medical education, like when you were in med school, EDS, in the textbook was that picture of that guy pulling his neck skin all the way out to here, right? So then that has perpetuated throughout the years. And so when a patient comes in to physical therapy or whoever's office and you see, oh, you have EDS. Can you do the party tricks? And it's like, whoa, like maybe we don't do that. Maybe we like don't start there as our evaluation. Cause then they're all like turning it almost into like a sideshow and like, don't make it weird. Like just assess the patient in front of you and like what they're actually having trouble with. And so A, don't make it weird. B, figure out what your face is doing. Because if you're making a face and because the patient's doing something and they have like excessive knee valgus and you know that that's contributing to their knee pain because of the instability, just like try to rein in your face a little bit and don't say, oh my gosh, like your patella is so unstable. Words like unstable, words like dislocation, weak, instability, these words, like we have to just be very careful and intentional about how we use them. Because yes, we should be educating on instability and we should be educating on dislocation, subluxations, like what to look for, but using it very intentionally and not just being like, oh, your hip's out of place. Like, whoa, like that patient's now thinking, oh my gosh, my hip is like not in the socket. Like I'm going to get hurt. Like it just kind of raises that threat level up to here. And in someone whose nervous system is already up to here, usually, and we're adding more fuel to the fire, like what is that going to do to the patient? We need to figure out where we can educate more appropriately of like, okay, you have a little bit more joint play in this hip right here. I'm taking you through this range of motion. I'm just feeling that joint move a little bit more than I would want it to. And that's probably contributing to some of the knee symptoms that you get Because if the muscles are having a little bit of a hard time supporting that joint, I love using the word supported. Um, and so we need to like get those muscles working so that it can help support. And that group project of the leg moving when you're walking, going up and down stairs can just work more effectively. And so, that one little joint is not doing all the work. And so using analogies, using words like support and like talk about what you can do to build it up versus like, oh, I see this impairment. And you're just going through a list of like what's like quote unquote wrong with the patient is just like a really weird place to start an encounter. And like, I don't feel good leaving that encounter if I'm the patient. So I try really hard to like focus more on like, okay, here's what we can do and here's what you can do and kind of talk about it that way. Cause yeah, your words do matter. There have been studies that have been done on that. So yeah, being more intentional.
Morgan, I want to pick up on that too. So I think that's such a strong point and really excellent because I know there's a counter argument to what we do for advocating for EDS and HSD and bringing awareness to it. In that, the concern is that are we over medicalizing patients, but by throwing these diagnoses out there. And there was a Wall Street Journal article not long ago by Dr. O'Sullivan who made these points that it's something that you're touching on too. That if we're giving these diagnostic labels just kind of haphazardly without giving patients instruction, then maybe it just develops more fear in them. They get this fear of movement. They think they're going to be unstable. They can't participate in their activities. And then it is like we talked about self-fulfilling prophecy in a way that this fear builds on more fear and then deconditioning sets in and it does make it worse. So my counter argument to that counter argument is that the concern is only in place if we're not educating patients and giving them the right avenue for treatment. And all these things that we're discussing today, are viable and they are effective, and we know that, they're tried and true. So this method of treatment is how we get patients better, and that's what we're ultimately here for, right? To get them back to living and functioning and enjoying their life. And I think that there is this kind of holdup in some patients that they think about it like Dr. Bluestein mentioned that there's this kind of stigma with exercise, and they're concerned like, oh no, I got to go out and exercise, and who really likes the stress of exercising. But if we do it with guidance, like you've illustrated, it is possible and it is very rewarding. So I know it's a very roundabout way of getting to my question is, what if a patient comes to you and they have joy in a certain type of exercise or a sport? I have patients ask me about this. I'm doing dance or I'm doing cheerleading or do I have to stop this? Is this something that I have to come to an end now that I've got this diagnosis? So what's kind of the step that you go through with him on that?
Oh, and it hurts me so much when I hear that because I get this all the time of like, oh, I read in this book that I like should never run if I have EDS. And it's like, okay, well, the author of that book has never met you. So like maybe don't take very generic advice from a book that you picked up. Talk to your healthcare professional directly about what you should be doing and what you shouldn't be doing. But that's the thing is like this messaging gets put online and a patient might get that diagnosis of EDS or they even just think they have EDS and they start researching. This is like the most well-researched group of patients I've ever met in my life. Like we're on the keyboard being like, oh, what is this? And I got to be knowledgeable about it. But we've kind of had to be because for a long time, the medical system just like wasn't meeting where you are. And so you have to find that information for yourself. But the problem is when the available information says, don't run if you have EDS, don't lift weights, your knees will explode. I don't know what it says, but like this is the information that these patients are getting. And so of course they're going to be afraid to move. If I read, oh, never run if you have EDS or don't let your knees go over your toes. I could talk about that for an hour. You can put your knees over your toes safely, by the way.
So you can still do yoga if you have EDS or HSD. Is that right? Okay.
Yes, you can do. There's ways to do yoga. There's ways to do dance. You typically find these hypermobile patients like to do these things because that's what they're good at. Their joints can move for days, and so finding where we can enter that activity, maybe find a better entry point of like, okay, if you're gonna want to do yoga or you're gonna want to do Pilates, whatever involves more range of motion. We have to make sure you have the stability to handle those ranges. As long as we work up to that, by all means, if you go to a yoga class for an hour and you feel really good afterwards and you don't have a flare up, by all means, if that makes you happy, please go do your yoga. Like that has so many benefits. Same with running. Like I've had a patient who like runs marathons and she comes into me and she's like, yeah, my last PT told me I had to stop running because of my knee pain with EDS. And I'm like, oh, but that's like your whole like thing that you like to do. Of course, we can find a way to get you to run. Like it might not look like someone else running. Like your programming might be completely different. Your strength training program on top of it to make sure you're ready for that impact is going to look different than someone without hypermobility. But like you're already doing the thing just fine. Don't take that away. That stimulus is like what your body needs. So yeah, I think the whole shift of like finding what patients can do and giving them that safe movement that they can gradually build up over time to build their capacity is like way of a healthier mindset than like don't do X, Y, and Z, because then the patient tends to take that and run with it, literally. Um, but they'll be like, oh, okay, it's like not safe to move, so I'm just going to not move. And then things get worse. So, yes, it's definitely better to find the right entry point and say, look, these absolutes are all over the internet. They're all over these books, but like life doesn't happen in absolutes. Everything is gray. So we got to figure out what shade of gray we're starting in.
And everyone's so different, right? There are people who are wanting to dance, but they're getting all kinds of injuries, having all kinds of problems. And it's like, maybe you can keep dancing, but you're going to have to really change what this looks like because, you're likely going to keep getting what you've been getting if you keep doing what you've been doing, unless if you can really strengthen or something like that. But, and then there's other people who are, like you said, managing quite well. And I think that one of the challenges like on social media is it's very easy for people to think, oh, they're just like me. And it's like, there's so many other differences and nuances, right? That a lot of people are just not aware of. And I see so many people online, giving each other advice. Non-medical people, medical people know not to give straight out advice online because they know that things are way too nuanced. But that is something that I see a lot that I think is a huge part of the problem. So I really appreciate that and looking to see how is somebody managing at that point in time. It's kind of like with pregnancy too. I see all the time people asking, well, I don't know, should I get pregnant? Should I not get pregnant? And then they'll talk about like the conditions that they have, but really more importantly, how are you doing right now? How are you managing and what have you been doing? Are there other things that you could do? And how important is this to you? It is very similar because like with dance or running or whatever, how important is that to you? So these are all like informed consent kind of things that you really just have to give the person the information and let them decide, which speaking of giving them the information and letting them decide, for patients that are listening to this right now and they're like, this all sounds great, but I can't either afford to go see Morgan or I'm not in her area. I can't afford to see a physical therapist outside of my insurance. I have to use my insurance. So I'm limited to who I can go see if I'm even lucky enough to have insurance and be able to do that. How do I get more individualized care and or within the insurance system? We all know that there's a huge problem because they'll look at your ankle if it's an ankle problem, but they won't look at anything else. What advice do you have for those patients?
Yeah, so there is some good free content out there. And I'm trying to put out as much free content as I physically can with these blog articles. We can link, I think I've written 2 specifically about EDS now, one about POTS and one about endometriosis, but I'm always just writing down ideas that I have, and eventually they'll all turn into blogs.
Oh, they're great, by the way, too.
Thank you.
I enjoy them.
I have a lot of like ideas, things to say, and like I understand that like not everyone is so fortunate to be able to afford individualized care like this. So I want to be able to give that information, and that's part of why we do this podcast, right? Is like giving that free information out to people that can have access to it. But I know like the EDS Society website has that like provider directory, and so you can like sort by your location and say, okay, is there a physical therapist near me that's like self-identified as someone who likes treating hypermobility and, wants those patients on their caseload. Okay, great. Now let me see if I can find, do they take my insurance? Another good resource that I've found is like local EDS Facebook groups. So people will post like, hey, I had a really good experience at, whatever PT clinic in Falls Church, Virginia. Like, go see so and so. And like a bunch of people will comment and be like, oh my gosh, like, do they take United Healthcare? And like, no one knows the answer to that question. So like, you have to do a little bit of digging of like, okay, go to the clinic's website, go to like the health system's website. Most hospital-based clinics take like more insurances. So that would be a good place to start. But yeah, it just like is a little bit on the patient to like do some digging, but like tap into your networks, like the Facebook groups, that provider registry, and just see if even in like some of your local physicians, like if you go to a rheumatologist, if you go to a cardiologist, see if they have recommendations, because they usually have patients coming back and saying, oh yeah, I went to physical therapy, or yeah, I went to this GI doctor. And that's how these referral lists grow. It's just patients talking about what works for them.
What do you look at as far as like safety goes and safety concerns? So, you said, yeah, keep running if you're running, or keep doing dance if you're doing dance. But what are things that you look for? You might hear from them that says like, okay, we need to rein it in a little bit and let's kind of level it off somewhat.
Yeah, so Dr. Bluestein actually touched on this a little bit earlier, where it's like specifically with dancers you were talking about are always getting injured. And that's usually my big red flag of like, okay, if you're doing a program, a physical therapy program, a strengthening program, and you're making some progress, but you're still getting injured doing whatever you like to do, something about that program needs to change. Some variable needs to change in order to make sure that it's actually preparing your body for the task that you're asking it to perform. And so, like for dancing, if you're, getting a lot of ankle sprains or something, for example, I like to look at, okay, what are we doing in terms of like strength? What positions are we strengthening in? Because some of these, people might be going up on point. Do any of the exercises challenge the ankle in that range of motion? No. Okay, well, there's somewhere that we can start. How do we load that position gradually without you flaring up? And so trying to figure out, okay, if we keep getting injured, like we have to change something. We can't just keep doing the same thing. What is that? The definition of insanity, doing the same thing over and over again, and expecting a different result. And then another common phrase that I like to use is like, nothing changes if nothing changes. We have to adapt that stimulus over time so that your tissue capacity can actually grow with you and support the higher demand.
And so when you're seeing that, so when you're kind of seeing this progress and these capacities are being met, uh, maybe, and certainly this is another saying I'm sure you in the field of physical therapy and your colleagues would be encountering, that no pain, no gain, right? Or is there a problem with pain? Tell me about that a little bit.
Oh, yeah, that's another one that hurts me a lot. There is pain when I hear the no pain, no gain. But no, really, pain is just a signal. Pain is like your body telling you that something's going on. You need to pay attention to me. It's say, hey, I'm over here, pay attention. It's not saying, oh, stop, or like, oh, you need to feel pain in order to make progress. Like, we typically hear that at the two ends of it, right? The bodybuilders are like, I gotta get the gains. I'm pushing all this weight. Like, if I don't feel sore afterwards, I didn't work hard enough. And we hear that a lot with like, especially college athletes that then leave college and start trying to figure out how to work out after that. It's like, okay, well, all I've been taught since the moment I was like 4 years old and I started doing my sport is like, you have to constantly work harder. Your worth is measured by how much, productivity you have. Cool. That's another topic for like work too. But like, you have to kind of get out of that mindset of like, if I'm not working as hard as I physically can, then it's not worth it. You have to figure out where to meet in the middle of like, okay, some like muscle soreness is good. Some muscle soreness signals that we gave that tissue enough stimulus to start that, mechanotransduction, if we want to get, super technical. That's like the process where the cells, start to build that, scaffolding to increase how much load it can handle. But we have to have a little bit of that in order to make progress. But I'm not saying we need to, be, groaning as we're going up and down the stairs. That is a sign that we've overdone it. Okay. Like that's not the thing that we're looking for. But if it's like, oh, okay, like I can feel like we did a little bit of work in my quads with that exercise we did yesterday. I feel like my tissues are responding to the load. it feels like a good muscle burn. I feel like I worked out, but I can still get through my daily tasks without being like, oh man, this muscle hurts. Like, that's usually where I'm like, that's the sweet spot. If you can feel like you did work, but it's not impacting you the next 2 days and you can still do all your activities, then we've found the right dose. But yeah, the no pain, no gain is like something I wish we could just like scrub from like the internet or like, those big posters that we used to see in the gyms. Like, that's got to go.
Yeah, and one group of patients I see this a lot. The kind of the conflict in their mind of what is the right thing to do are ballet dancers. And I know Dr. Bluestein has experience with this, and my wife as well did ballet, but you're kind of taught to just push through, right? Keep pushing and keep pushing. And it can be to the detriment. So I guess what I'm taking from this, what I'm hearing is that that some stress is good, but and certainly there's an expectation that you will want to have a recovery period. But if you're noticing the recovery period is prolonged or longer than what you might expect, then that's where, okay, there may be some damage that's done. And I guess maybe this is what Dr. Bluestein referred to earlier. Some patients only do one visit with physical therapy. And do you think maybe it's because they, pushed it and then like they were tired and sore the next day? Like, I don't ever want to do that again. Do you think that might be what's going on?
That has to be a little bit about what's going on. Cause like, I don't know about you, but if I go to a doctor and like that encounter didn't go well, I certainly am not going back to that doctor. And like that doctor never gets that feedback of like,
Mm-hmm.
oh, this patient like didn't like get what they needed out of this encounter. Like maybe I need to reflect on how that went and like what to do better. So it's the same thing with physical therapy. If you have your first encounter with a physical therapist, or even if you go like 3 or 4 times and then you're like, oh, okay, like this is not for me, like I'm just gonna go, but you never like say anything to the physical therapist. Even if you say something to the receptionist or, whoever's taking the phone call of you canceling your appointment, they might not relay that information to the physical therapist either.
Mm-hmm.
And so I usually ask patients, like this is an ongoing discussion. If at any point like you feel like this is not working for you, let's try to like fix it. Let's pivot, try to get past it and figure out like a better way to work together. Um, but if we're not for each other, again, you're not for everyone, um, then I will help you find someone else. And, I'll take that feedback of like, okay, like we just weren't a good fit. Like I need to maybe work on X, Y, and Z going forward, so that I can have maybe less friction in another encounter. But yeah, that conversation like is really important for both parties to just figure out like, okay, how do we progress from here?
And that reminds me of something that you had commented on before we even had this conversation about shifting the clinician's role from gatekeeper to guide. And I think that's a good way to think about it.
It really is. And like Dr. Knight was saying just before this, where, you have to find the right amount of stress. You have to find the right type of stress too. Like structured stress is kind of how I describe this of like, I, again, as the guide versus like the gatekeeper, I'm like trying to figure out, okay, I'm like that guy in It's Always Sunny in Philadelphia where there's like the red strings everywhere. You know the guy I'm talking about. I'm like trying to put the puzzle together of like, okay, this is where your symptoms are happening. Let's like, change this variable. But you have to have that structured stress in like the most controlled experiment possible, while also still understanding that there's those outside contextual factors that like I don't have control over. Maybe the patient has like a really busy work week coming up. Like I can't do anything about that. I can help give that patient, some diaphragmatic breathing, some like stress reduction tips, but like sleep hygiene, all these things that I can like try to like influence the outside stuff, but that's still part of your body's inputs. Like that is part of the stress that like the body has to figure out what to do with. And so that's another important part of rehab. And like that's how it's, really important to be a guide of like, okay, I know your work week's about to be really stressful and you haven't been sleeping very well. How's your nutrition? Like what other things can we help control how much like structured stress we're introducing? Maybe we don't progress your exercises as much as I had originally planned this week because we know you're going to have a more stressful week. So that structured stress that we're adding on top of like the other stress that's going on, we can kind of figure out how to play with those variables. And it's a lot easier to do that if you're working as a guide versus a gatekeeper of like, here's the strict list of things that you need to be doing because you have EDS. Like, no, this is a real person in front of you with real life things going on. And you have to be able to fluctuate with that with them.
And it's
It
a real
seemed chaotic.
partnership, like you
I'm
said.
sure at first, very chaotic, right? And I know that, the episode you're talking about, and it's like a beautiful mind, right? That movie diagram with all these equations in the background.
Mhm. That is how it feels sometimes. And like, I kind of get a little bit of, I get joy out of that too, where it's like, oh, I can like put this puzzle together, like help this patient figure things out alongside with them instead of just saying, here, me as the clinician, I am telling you what to do. I like really actually flip that and be like, you're actually going to tell me all the information I need. I'm just going to help you figure it out.
Yeah, and like you said, that at the very beginning, that's how you have a real partnership. And I sometimes feel guilty when I'm going to see my physical therapist again, and if I've been traveling or something, I haven't been keeping up on my exercises. But like you said, they're a guide, not a gatekeeper, and she never makes me feel bad. She just says, "Okay, well, and sometimes she'll even flip it and say, well, actually, it's great. You're still doing well, even though you weren't able to fit in your exercises. And sometimes I don't necessarily have that mindset shift that she'll remind me about. It's like, yeah, good. It's a really good point. That we end, I think you know this, that we end every episode with a hypermobility hack. Do you have a hack for us?
I think the hack has just got to be find the joy of movement, like you have to find something that you enjoy doing. And so, my example that I give all my patients is like every morning when I'm making my coffee, I will be dancing around my kitchen with my dog. I'm playing, Mariah Carey or Celine Dion, 90s mom rock or whatever you want to call it, or like a boy band. I just put on something that like just allows me to like dance around and move throughout the kitchen and just start my day with a little bit of movement. I always feel better after I do that. And like anytime I'm having like a stressful day with work or patient care, like I will take a little bit of a movement break. And that might look different depending on the context. But like sometimes in my car, I'm like, okay, I gotta like really, re-regulate my nervous system after that. That was like a really heightened in terms of emotion, patient encounter, or maybe I just had a difficult phone call with someone. Like I'll find a way to like, maybe shake out or like go for a walk. But my favorite one is just like a dance break. But like people don't think of that as exercise. And I'm like, no, that's getting your body moving. And if I can give you just a little bit of movement throughout the day that you're going to enjoy, then you're way more likely to do it. And so that's my hack, is just to find some movement that you enjoy.
Yeah, I love that. And for a while, I was really super into Zumba. In fact, I got certified as an instructor, but I had a lot of difficulty like teaching the classes because, of course, you have to memorize all the routines. And I would do a lot of it mentally, but it was still, you still kind of have to do it a little bit physically. And it was really challenging. So I had to stop teaching. But it was funny because I remember being in Zumba one day and the instructor in the middle of class saying something like, well, it doesn't matter. It's your workout. And I literally went, this is a workout? Like it, I had never thought of it as a workout before. Like I mean, I knew that it was exercise and I knew that it was, but it was just so much fun that, I just hadn't really framed it that way. So I love doing what you enjoy is going to be so much more likely to be successful, and you're going to find time for it in your schedule, right? As compared to, trying to make yourself, force yourself into something that you hate. Well, this has been a great conversation. And before you go, can you let us know where we can find you, what kind of projects or any special thing that you want to share with the audience before you go?
Let's see. Special projects. Always look out for blogs because I write a lot of things. I have a lot of things to say and I put them out there. I know I'm working on a little bit of research with Dr. Knight right now, and the team there. So that'll be cool to be coming out soon. Let's see, what else? Where do you find me? I can link the like blogs in the show notes so that you can find my like provider profile is linked there as well.
And you're on the EDS Society provider directory. You're listed there.
Yes, the EDS Society provider directory. If you search like by Northern Virginia, you can find me there. Technically, I'm on Instagram, but it's like It's just a little fun project. I'm not putting out like a ton of, the educational content because again, I am like a full-time clinician. So it's really just for fun and like connecting with my patients and like getting research in a more digestible way.
Okay, fantastic. And we will make sure that we have those links in the show notes. It has been so great to chat with you, Morgan. And of course, pleasure to have you here again, Dr. Knight, as well. And I know that we're going to get some really great feedback on this conversation and really appreciate you sharing your knowledge with us. I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at Hypermobility MD. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.